Welcome, everyone. I'm going to talk about the Evaluating the IRIS project that Andrea just explained. You can just call me Mei-ling, and I'm really pleased to be presenting this work that we've done together with the IRIS team over the past 5+ years. Andrea already did the land acknowledgement, but I wanted to just add a little piece to that. This is how we typically do our land acknowledgement with our community engagement process and with our community advisory boards. So this has one piece of our land acknowledgement in a few different languages in which our team works. We have Farsi, Spanish, and Tigrinya. And with our land acknowledgement, when we're with community, we also talk about and consider the link between colonialism and borders in the land that we call Canada, and consider how forced displacement and control of movement have impacted Indigenous people in Turtle Island and from other places around the world. We see and we hold up their resistance to these historical and ongoing processes, and we're grateful for the values and wisdom of Indigenous nations and peoples who've created principles of respectful community engagement with communities. Those are respect, reciprocity, relevance, and responsibility. We strive to uphold those in our relationships with Indigenous communities here on Turtle Island and the world over. A little bit about me, just so you kind of know who I am and what I bring to this work. I'm Mei-ling, pronouns she, her, and I am an immigrant and a settler here. I'm of white, German, and Chinese descent, and I come from a large, extended, diverse immigrant family. As Andrea said, I'm a family physician and also a clinical assistant professor in the Department of Family Practice. And I work at the Umbrella Multicultural Health Co-op with the team that you can see there. And I'm also the parent of 2 kids and 2 cats. In case you like any of those things, we can chat about that. So that's just a little bit about me. I have the privilege of working in a profession that's really honored, and also working with people that teach me a lot. So I'm looking forward to seeing how that works together with what I want to present with you here. What I'm going to talk about today is our project, our study design, and then some key findings and recommendations, and then hopefully have a good time for discussion. So the IRIS project, as Andrea said, is the Evaluating Inequities in Refugee and Immigrants Health Service Access Project. We undertook this project just with some background knowledge that immigrants are, a large portion of the population, and they experience inequities in access to healthcare. Some of those inequities are due to structural factors like racism, precarious work and housing environments, and immigration status. And a lot of these existing inequities within the health system were magnified by the rapid transitions that happened during the COVID-19 response, which happened like smack in the middle of our project. Just for some context, when we're thinking about borders and immigration, we recognize that the borders of the province of British Columbia, they were defined through colonization on top of the lands of more than 200 Indigenous nations. You can see in the picture there how the borders trace on top and divide up nations and groups of people that were already living and already had thriving communities. These colonial processes are both historical and ongoing, and their kind of features were forced displacement and internal migration, and they continue to be resisted by Indigenous communities. For our purposes here, we think about the relationship of the borders to our federal government. The Federal Ministry, Immigration, Refugees, and Citizenship Canada, or IRCC, controls movement across their defined borders. They issue travel documents and they screen potential permanent and temporary residents, and they determine admission into those categories into Canada. The province of BC is most densely populated in the Lower Mainland, so the area kind of surrounding Vancouver, including Surrey, Burnaby, New Westminster, and that includes both the Vancouver Coastal and Fraser Health Authorities, and about 80% of immigrants in BC live in those two health authorities, compared to 50% of people who are citizens. I just have a little link here too. If you're ever interested, there's this really great website that goes through a lot of the different languages that are spoken by Indigenous communities throughout British Columbia. There are many, many languages and several language groups that you can see there. And if you go to that website, then you can hear words in some of the languages. And so when you're traveling around BC, you can learn to speak a little bit of the languages that were and are originally spoken there. In this project, we use the term immigrant, which kind of includes the idea of immigrant, migrant, and refugee because it includes the diversity of refugees, immigrants, newcomers, and migrants born in other countries came into Canada. And this includes long-term and recent arrivals, asylum seekers, economic and undocumented migrants. This project started in 2018 and is wrapping up this year in 2024. And our overall goals were to understand and generate recommendations for policies and programs that improve health, well-being, and access to health services for people who are immigrants in BC. And that includes primarily, in our project, we focused on sexual and reproductive health services for women and COVID-19 related testing and care. We have a mixed methods study design that kind of has three components: community engagement. I'm going to talk more about all of these, so I'll just kind of list them now. But we think about community engagement as one central component, and then we use quantitative analyses of administrative data, and then qualitative interviews with immigrants and service providers. Community for IRIS is a continuum, and we collaborated along this continuum to co-develop this structure for our project where community engagement forms the backbone of our study design, and our responsibilities in each of the different aspects of our study are articulated at each stage so that the expectations and our responsibilities are clear. And the way we think about community as a continuum includes team members with experiences of immigration, community advisory boards run in several different languages, English, Farsi, Tigrinya, and Spanish, partner community-based organizations, including the ones here at Watari, Mosaic, and Sanctuary Health, and then our interview participants. The administrative data that we use are data that are routinely collected by health and immigration systems for administrative purposes. These are, data that are collected every time you might interact with the healthcare system, go to the hospital, or see a doctor. And they're primarily collected through billing data on the medical side, and then, immigration data, which is data they collect when you engage with the immigration system. These categories are assigned by the systems, and so they may not reflect identities very accurately, like gender and race. There are limited proxy measures that we can use that inform social position, for example, living in a low-income census area. But these administrative data are quite useful for telling us about processes. So how people are classified by systems and how that impacts how they interact with systems, and how services are organized and delivered in large population-based settings. The administrative data we're going to present today only includes people who are registered for MSP. That's our provincial insurance plan. These results do not reflect the healthcare experiences of all immigrants in BC. And the inferences are all from our team and not the opinions of the data stewards or the organizations that provide us the administrative data. The qualitative data that we use comes from multilingual in-depth interviews that are done in the language of the participant's choice with the various team members that we have that speak a variety of languages. We analyzed interviews both before and during the COVID-19 pandemic. And then we drew from that data on sexual and reproductive health needs and access, as well as pandemic impacts. And then we employed a team-based coding and thematic analysis approach to those. So I'm just going to talk through our key findings and recommendations that came from, 5 years of our study. And although although barriers to healthcare are present for all immigrants, our research has highlighted specific areas that really meaningfully shape their access to and experiences of healthcare. These are current immigration status and its associated access to health insurance, along with health service delivery and organization features like past immigration experiences, language, culture, community connections, and intersecting social and economic characteristics. Today, I'm going to discuss cross-cutting findings and our associated recommendations that highlight opportunities to better design care that meets the specific needs of diverse immigrant groups while ensuring all services are accessible to immigrants broadly. One of our key findings is just that immigration status is a foundational determinant of health access, and that fear of collusion with enforcement agencies jeopardizes needed healthcare. In this study, using administrative data to examine COVID testing in primary care according to immigration status, we looked at citizenship, permanent residence, and temporary status residents. And we found that people with temporary immigration status were at a much higher risk of COVID-19 transmission, especially during the big waves that we had. And even though people in this study had access to MSP or insurance, the temporary immigration status comes with a context of precarity that is associated with poorer health outcomes. In the same study, we found that there were income gradients across all the immigration categories, where test positivity was higher for lower income neighborhoods. And that was true in all of the groups, as you can see, but in the temporary status group, it's higher. And we found that across all of the different things that we analyzed, there is variability in test positivity between sex or gender, age, income, rurality, and health authority. But within every category of analysis, people with temporary status had the highest test positivity, and they were more likely to live in a lower income neighborhood and have reduced access to primary care. Qualitatively, we learned that fear played a really big role in determining health access for people with precarious status. In particular, fear of collaboration between healthcare and law enforcement services, as well as fear of being turned away. This person told us, they had told us that if we went to a hospital, they would immediately inform immigration or the place that I didn't have documentation. Our recommendation here is that we decouple healthcare and immigration status, that we extend permanent residency to all immigrants residing in Canada, and we implement access without fear principles at every level. Questions that you might consider applying in your own places of work or organizations are, is your organization aware of access without fear? Have you developed policies to apply these principles in practice? Do you communicate these policies to clients so they know they can access care without fear of being reported? And have you ensured that all staff are aware that they have an obligation to protect patient information, including from the Canada Border Services Agency and other law enforcement agencies? The next area we found was health insurance, where linking insurance to immigration status causes barriers to health access, that wait periods for insurance are harmful for health, and confusion about forms of insurance impedes care. Here, because BC is one of the few provinces that has a wait period for provincial insurance, for immigrants, this created stigma, high administrative burden, and negative health outcomes. This person says it's access. If you don't have a status or a precarious status, it's bad. And if you just applied for a student visa or work permit, you have to wait 3 months. And if during those 3 months you need medical attention, for example, me being pregnant, you can't access it. And supposedly health is a right. It's a right that should be given to everyone. Here, the link between immigration status and health insurance eligibility, really creates stigma, burden, and negative health outcomes, and palpable discrimination, especially for people with precarious status. And this ultimately calls into question our sort of concept of our system as being universal. Even where people had insurance, such as refugees who have federal insurance or temporary migrant farm workers who have a third-party insurance chosen by their employers, confusion at the level of service providers about how to accept different forms of insurance creates barriers for patients and service providers alike. Here, one of the people we interviewed who's a service provider said, they need to know, okay, this person has federal coverage, and then the patients need to know which providers they can go to, including obstetricians that they might need that are registered under Blue Cross, which is the federal health, so that they don't get billed. So it's, yeah, this confuses me. And I've been doing this for 7 years. So how do folks know this? It's really, really difficult. Lots of barriers. Our recommendation here is to unlink provincial insurance from immigration status and abolish the 3-month wait period. We suggest that people provide care regardless of insurance status and ensure that patients know that that's there. And then ensure that all types of insurance are accepted. And we have these suggested questions you can use to apply. Does your organization clearly understand the different types of health coverage that people using your services may have? Do you have ways of supporting access for all coverage types, like provincial, interim federal health, private insurance, or people with no insurance? We also found features of health service delivery were important, such as language discordance, which is when unaddressed, results in inequitable or discriminatory health outcomes. Just the knowledge that immigrants are culturally diverse and that gender intersects with immigration, discrimination, racism, and trauma for a lot of immigrants. And many people arrive with experiences of trauma that influence how they interact with care. Immigrants are not a monolith and have a diversity of culture and language. So not only is language interpretation essential, but an approach of cultural humility, recognizing that there may be nuance necessary for communication and care. Like this person who says, I can say I have an appointment, but I can't express what I really feel because there is no one who speaks my language. Spanish is only a second language, so a person like that can't really express what you want to say, or you go to a clinic and there's no one. There's no one. This person spoke an indigenous language, so they're already speaking through a cultural kind of web. And so, it's hard to really get to the real meaning of what this person might want to say. And that takes time and it takes care to be able to get there with people who are from a variety of cultures, as everybody is. In this study using administrative data, I'm just going to ask you to focus down here. We looked at primary care visits, both before, during, and as we kind of recovered from the initial changes of the pandemic. And what we found is that our seniors, especially who are immigrants, were very impacted by these changes. We found that older recent immigrants that had lower assessed English proficiency, they started out behind here in their primary care access. Everybody changed. Their in-person visits went down during the pandemic and then slowly came back. And then virtual visits obviously went up at the same time and then slowly trickled down. But as you can see, these older immigrants who are probably the most marginalized of this group stayed behind in their access. They fell behind during the in-person care, and they stayed behind throughout the virtual care usage. We also found that people's experiences of migration came with them to where they are here. And that impacted both their expectations of the healthcare system here and how they navigate it, and also just how they experience and their need for healthcare. This person stated, although we were in a very bad condition in transit, I did not face this many problems compared to here. I was under stress during pregnancy and after that too. This study, using administrative data to look at mental health services by income and immigration experience for youth, found that Looking at primarily community-based services, non-immigrant youth used more outpatient community-based services related to mental health. All service use in mental health increased for all groups at the start of the COVID-19 pandemic, and that there's an income gradient, and it's reversed between immigrants and non-immigrants. So you can see in these different income groups, which are the different shaded lines, the lower income youth used more services relative to the higher income youth who were not immigrants. But for immigrants, that's reversed. Higher income youth use more services than lower income immigrant youth. This starts to change when we start looking at hospital and involuntary psychiatric admissions. We found that, like before, non-immigrants also have more emergency department visits and hospitalizations, but the gaps are smaller than for outpatient care. And that a higher proportion of hospital admissions among immigrant youth are involuntary relative to the non-immigrant youth. So you can see down here is immigrant youth, and this is the only place where those lines cross over, and the immigrant youth have higher proportions, which is for involuntary psychiatric hospital admissions. We have some ideas about why that might be, but we welcome your thoughts too. We were considering that, based on the literature, it's more common for police to attend emergency calls for immigrant and racialized people. And also the fact that, as we saw on the previous slide, barriers to community-based services, some of these issues might be mitigated, might mean that there are higher acuity or crisis presentations by the time someone really does acutely need mental health support. So what we recommend here is to implement policy to meaningfully support language discordance for everybody, implement culturally responsive and trauma-specific policy and practices, and evaluate and provide ongoing training throughout to ensure that those things are consistently practiced, and then to stay accountable to communities. The questions we ask people to consider applying are all staff aware of interpretation resources available, and do they know how to use them? Are you aware of different cultural communities that may access services you provide? Do you prioritize hiring people with relevant lived experience to provide services to these communities? And do you understand and resource trauma-specific practice? And do you have systems of accountability in place to make sure that you uphold your responsibility to communities? And then finally, some of the factors around how the health system is organized were really important. This primarily was around information about just how the health system works, how to navigate it. And the fact that this information is very scarce and people's knowledge about what their rights are around the healthcare system, because it was so lacking or so difficult to find, that obstructed healthcare for immigrants. Even if the healthcare was available, it was difficult to know how to get it. We also found that community-based organizations fill in gaps created by political and economic structures, and especially for people who are refugees or with precarious immigration status. And in those cases, sometimes the support provided by community-based organizations can be life-sustaining. Here, this is a person that we were sort of talking about existing relationships with healthcare providers, and then what that's like in our current primary care landscape in BC, and then how that changed during COVID. So this permanent resident said, "It was very worrying for me because one time during COVID, my son got a really bad cold. We didn't have a family doctor. I called the walk-in clinic and they told me, no, they won't accept us because we're not their patients. I mentioned to them that we'd already been there a few times, but they said, no, since the doctor there is not our family doctor, they cannot accept other patients due to COVID-19. So there was just a lot of confusion about how to get care, where to go, what a care relationship looks like. And then all of that suddenly changed. So even people who might have figured out how to access care before the pandemic then struggled when things changed during the pandemic. In this case, the role of the community-based organizations came through across basically all of the studies that we did. It was often life-saving, and we found that the community-based organizations were closely connected to the immigrant communities, but they were under-resourced. They were often filling in gaps in the system, and they were bound by very strict funding criteria. So sometimes, for instance, if you get funding from the federal ministry, they will say, well, you can provide services to these people and not these people. And that forced the community-based organizations to kind of try and split up their care or their services in really problematic ways. But when they were able to provide services, they were really instrumental in basically helping people gain access, stay alive, and feel a sense of community. This person said, here in this community-based organization, they've helped me a lot and I'm receiving medical care, but I wouldn't have known about them. If I wouldn't have known about them, I don't know what would have happened because the hospitals wouldn't have provided me the service. They wouldn't have wanted to see me. In this case, we suggest that um, at all healthcare settings that you ensure clear information in relevant languages and at different levels, accommodating people's ability to read. So, written documents, videos, other types of ways to share information about system navigation and give that proactively to immigrants. Maybe offering orientations to the health system as part of a routine part of arriving in Canada. And also that community-based organizations need to be adequately resourced for immigrants with any status and connected to health services planning so that we can efficiently integrate the incredible wealth of knowledge and skill that is contained with the community-based organizations and use that to complement our healthcare delivery. Some ways to apply this in practice are to ask yourself, are pathways to access your service or program clearly communicated? Have you thought about who may need your services but hasn't made it through the door yet? Do you know immigrant serving organizations in your community and do they know you? Do you have relationships with groups or organizations within cultural communities that may access your services? So religious groups, for example, or advocacy organizations where different immigrant groups might be accessing their services. It would be important to have relationships with them as well. Ultimately, what we found is that access barriers to care for immigrants are structured differently based on immigration status, health insurance, language, culture, and discrimination. And that health services should be designed with immigrants in mind and then together with them in practice. Participants, community-based organizations, CAB members, and team members all identified ways that community members helped each other, and they had practical recommendations for how to close systemic gaps and create communities where immigrants can thrive. Listening to them and taking responsibility at all levels, from individual to health service to municipal, provincial, and federal, can make these ideas a reality. And together, using that information, we can meaningfully address barriers with community-centered action at all levels, from individual to federal. We wanted to make sure that we thanked everyone who had participated in our work from the beginning to the end. We are especially grateful to the study participants and community partners for their time, their trust, courage, and valuable contributions to this research, as well as our study staff for their expertise. Thanks to all of you for joining in and listening, and I'm hoping that we have a rich time for discussion. You can see our website is there, and that lists basically all of the papers and other infographics that we have. You can read all of the information that I shared from the studies in more depth. And reach out to me at any point that you wish if you want to connect or ask questions or share some information that would help us share some of these data more broadly.
Well, thank you so much, Mei-ling, for this beautiful overview of this really community-based project. It's been such a pleasure seeing the project unfold over the years, but now seeing it all, and I'm sure there's maybe a few more pieces like in the books, but like it looks beautiful. It's a really comprehensive piece of work. So congratulations. So with that, I just wanted to open it up for questions. Like I mentioned at the beginning of our session, of our hour together today, please feel free to put your questions for Mei-ling and the team in the chat. And then, yeah, we can address them and hopefully have time for some, lively discussion. I see that we do have one question that just popped into the chat from Jen. She's saying, amazing work. I'm wondering if you have separated your data around access to pregnancy care and interviews with pregnant patients. Would be lovely to have access to this for advocacy.
Yeah. Yes. Great question. We don't have administrative data that separates these pieces, but we do have a lot of qualitative data. Most of our qualitative data was originally, so what sort of happened in our case was we started out doing a project that was focused on sexual and reproductive health. And then in the middle of it, the pandemic happened, and we kind of ended up doing multiple things, learning about the impacts of COVID on both sexual and reproductive health and primary care and mental health. And then also continuing our interviews on sexual and reproductive health. And so in this case, we do have a lot of qualitative data across a few different studies that talk specifically about pregnancy care. And in particular, they describe people's experiences of a number of things. So they describe a lot of people's experiences when they have precarious status of being, scared to get care, having trouble finding care when they needed it, being charged for care and being afraid of not being able to pay for it, being in the hospital and being treated in a variety of ways, sometimes in a way that carried a lot of stigma around their immigration status. And then also they described a lot of experiences of people coming in and asking them for money, like when they were in the middle of things. So maybe someone had just given birth and then they get a visit from hospital finance. That's like, okay, so how are you going to pay for this? There's a lot of qualitative evidence we have on that, and we can definitely speak together about how we might bring that forward in some of the work that we do together around advocating for access to pregnancy care for people who have precarious status.
Thanks so much, Mei-ling. There's another question from Wiebke. It's in the Q&A section. Again, a big thank you for your presentation. And then Wiebke is wondering, have you looked at attachment to primary care providers in immigrants compared to non-immigrants? And then the second part of the question is, how does this influence visits to emergency department care?
Yeah, that's a really good question. We have looked at sort of primary care service use, so we can look and see how immigrants and non-immigrants use primary care. And so we talked a little bit. I'm sorry, I literally just like flashed some graphs at you. I kept going. So, happy to like talk about this later if that's helpful in more depth. But just to say that we did find that as we showed for older people and for youth trying to access mental health services in the community, they do have less access. Attachment to primary care providers is tricky to measure in admin data currently in British Columbia because we don't have a clear attachment designation. The Ministry of Health uses kind of an algorithm to assign attachment, where if you visited someone 3 times in last year, there's like a bit of an algorithm they work through and they just say you're attached. But that's only in the admin data level, and it doesn't speak to the actual attachment relationship that someone has with a primary care provider. And so it's a little tricky, although that could change maybe with the new provincial registry that they're rolling out right now, kind of as we speak. So it's hard to say exactly a lot about the quality or of care, primary care that people are getting in the admin data. And in terms of emergency department use, we did look at that a little bit in our mental health data as well, finding that immigrants were using they still weren't using as much emergency care for mental health services, for example, but the gap was smaller than the community-based services. And it's hard. I mean, it makes sense to us. A lot of people in our qualitative data did say that they sort of felt emergency room was like the only place they knew where to go. So there's sort of a lot of different reasons people might present first to the emergency room rather than primary care. Some of that was related to confusion about navigation and the model of care that we have, which is the gatekeeping model of primary care, where you have to have a primary care provider send you different places. That's for most care except the emergency room. So people knew they could go there, and we would expect to see them use the emergency room more. But it's hard to draw a connection between those because sometimes there just are emergencies and people need to use the emergency room. So it's not always clear cut, the relationship between primary care and emergency department use. But we did try to show it a little bit in terms of access to primary care for older people and for mental health services. Oh boy. Oh gosh, the questions are coming in. Okay.
Yes, they are. So maybe we'll move to the next question in the Q&A from AJ. AJ is wondering, can you tell us about the logistics, challenges, and successes of working across languages as a research team and with participants?
Oh, yeah, I could do a whole talk on this. Great question. I think point I would say is that all of the challenges and the logistics are surmountable with an adequately resourced team and approach. So what we did was we worked with staff people that we hired onto our team that were from many of the communities that we wanted to work with. And so that we automatically had people who spoke a variety of languages and then who would reach out to do interviews and to support the community advisory boards. They were run in the language, that was people's preferred languages. And so that did entail a fair amount of logistics and planning, which is why we made that community engagement kind of model where community engagement is the backbone. It kind of directs what we do at all the different levels of or stages of research. And we reviewed that and iteratively designed that with our community members to make sure it made sense and that it helped us sort of design processes that we could follow to make sure we were doing community engagement as we went in the way that we wanted to do it. But there were a lot of challenges because primarily in our current funding landscape, community engagement at that level is not really very supported or broadly funded. I would say that relative to what, I don't know, there's lots of other folks in this Zoom room who do community-based work, but it requires infrastructure, and it really requires building of trust and relationships. And that requires sort of the sustained commitment over time. And that's hard to do in a research setting where you're only getting like little pockets of funding from different places to try and like have that sustainable support for the community engagement piece is the biggest challenge. But I think we were successful in getting a variety of different sort of funding opportunities to be able to support that. And it made a huge difference in the quality of our work. Should I go to the next one? Thanks, AJ.
Yeah. Thanks. Yes, go ahead. Go to the next one. In the
I'm not
Q&A.
going to get to all these questions. Okay.
I know, and there are so many.
They're really good questions, so I wish I could spend a little more time. There's a question here about if the utilization of screening for cervical cancer. Oh, I can just answer this a little bit from my personal practice. People did talk about screening for cervical cancer, and it depended on where people were from in terms of their awareness of it. The evidence shows that by and large, most immigrant, like people with a cervix who would be eligible for cervical cancer screening are screened at lower rates, except in certain settings, like in community health centers, where they have sort of adaptive models that, bring a lot of information to people in a culturally sensitive way. In terms of the self-collection practices in my personal practice, I have found that it really has opened the door to a lot of people for whom screening with a speculum was a barrier. And definitely our acceptance rates, just in my own practice, which is all immigrants and refugees, of cervical cancer screening with the new HPV self-screen has gone up. It's great.
Mei-ling, there's another question.
Oh my gosh, okay.
Jumping around. There's also questions in the chat. So just want
see. Oh gosh.
to get lots of likes and sub questions there. So that one is actually from Shira, and it's just like saying again, like, beautiful job summarizing the work that you and the team have done. And so I'm wondering what kind of response you've received in discussing these findings with your clinical colleagues and audiences. For example, to what extent do providers feel the system could implement these types of changes? What are the barriers? Yeah. And then there is an additional sub-question from Esther as well. To add to these questions, are there any idea how government can ensure that policy changes are properly implemented across various practices as well?
Yeah. Wow. Amazing questions. Thank you. This is really important to think through. Yeah. In terms of where we take this data from here. And so I think what I've found in sharing this information in a few different places, is that with clinical colleagues, people are very keen to know about how they can provide better care. I think everybody's invested in that. The barriers are related to the infrastructure that we have, especially around primary care right now, where, people are kind of, the primary way that primary care is funded is kind of fee for practice, or this new model that's similar to fee for practice. And it really incentivizes people to like have really short visits. And that makes it more difficult to provide care that's, with an interpreter, or, culturally or trauma specific. But people are very interested in knowing more. I do find that this has been kind of useful to bring to different tables where we're talking about different service models. So when I sit at a table with other community health centers, they're very interested in some of the ways that we've described getting, being more accountable to community, having community members on our board of directors, and kind of working with models. Like at Umbrella, we have cross-cultural health brokers that are part of our team and that are deeply connected to the communities that we serve. And so I think that, we do see avenues where implementation is possible. We have found that when we work across community health centers, we can bring in some of these ideas and they're very keen to implement them. And it would be great if there would be even more community health centers, and that type of model spread across British Columbia, not even just for immigrants and refugees, honestly, for a variety of people who struggle to access care. Community health centers are a really great model. And we've had an ongoing series of engagements with the College of Physicians and Surgeons, actually. They reached out to us initially because they were in the process of revising their practice standards. So they revised their practice standards around informed consent, and they reached out to us to talk about how does that look for people with language and cultural diversity. So we added some elements to the practice standards, which are applicable across anyone who's registered with the College of Physicians and Surgeons of BC. And they reached out to us again this year because they're now revising their practice standard on access to care free from discrimination. And so we're doing some consulting with them around that. So that's like those are some of the different areas where I think implementation is happening or people are open to it. The barriers are many, there's different levels at which things need to happen. So federal government does some things, provincial government, health authorities, individual providers, and they're all kind of siloed. So trying to coordinate between them is a challenge and a barrier. And then just making sure that the things that are helpful for immigrants are adequately resourced is an ongoing issue because it's an equity issue, but people don't always see it that way. And so that's where some of this evidence can be really helpful and persuasive, I think. In terms of the question around policy changes and implementation, I mean, that's the key, the implementation piece, right? The policy can be there. I mean, we find this all the time. Like, if, for example, I was problem solving earlier this morning with a colleague because we have a patient, they have the federal insurance coverage, but we can't find a provider who accepts this insurance coverage. You know what I mean? It's like the policy to cover healthcare for refugees is there, but the implementation is very scattered. And so I think that's where some of those accountability pieces are important. I think anytime that you can have lived experience expertise integrated into your governance, it's really helpful. And that can happen at the community level where you're providing services or at the federal or provincial government level. I think there's no reason why, in terms of their accountability, they should be hearing, I think they should reach out to the communities in need and hear from them and actually try to listen and apply what they say. I think that would go a long way. I wonder if I have time for any more questions. Maybe one more.
I think one last one from Anna. Again, saying great talk and thank you for sharing all this information with us. I'm wondering if the study centered immigrant folks of all genders, or if there was some evaluation gathering focused on gender diverse and women migrant folks' experiences in accessing healthcare.
Yeah, so initially we primarily worked with women and self-identified, and we then brought in to include men and all genders when we were talking about COVID, and we didn't end up recruiting that many people from a variety of genders, I would say. So I don't think that they were necessarily centered in the work, although it was something that we were intentional about and tried to attend to wherever we could. So we didn't gather a lot of information specific to people who might be trans or non-binary, although we do see lots of trans, non-binary, and other genders of immigrants and refugees who arrive here, and they do have very specific needs in terms of accessing care. So I do think there's a place for that work, and it would be important, but we didn't have a lot of specificity around our findings for that group of people in this specific study. Does that answer your question, Anna? Sorry, it's hard it's just when it's typing and not talking.
Yeah, well, Mei-ling, I think in the interest of getting everybody to their next appointment, their next activity this afternoon, I think we're going to wrap up. Thank you so much for this beautiful overview of the work that you and your colleagues of the IRIS team and community partners have collectively engaged in over the last 4 or 5 years. Also, thank you everybody for coming and for your amazing questions to Mei-ling. It's really great when we get lots of questions and have time for vibrant discussion.